this thing on? Hello? I'm not sure that it is, actually. No? It says it's on. Yeah?
Mine's on.
How's that? Hi, welcome. I'm Aaron Cohen. I'm an associate professor in the Department of Medical Informatics and Clinical Epidemiology. You are at, if you don't know, one of our IDL industry leadership talks. The IDL is the Informatics Discovery Lab, where we're trying to create a entrepreneurial informatics culture and establishing some relationships with commercial entities. Today, I'm very pleased to introduce Kaveh Safavi, who has both an MD and a law degree. He's Accenture's health industry lead for North America, and for those of you who don't know, Accenture is a global management consulting and technology services and outsourcing company that has a strong focus on healthcare. Kaveh oversees the payer-provider public health offerings and is responsible for the health strategy, growth initiatives, and market capabilities of Accenture. He joined Accenture coming from Cisco in 2011, where he led the global healthcare practice. Prior to that, he's at Thomson Reuters as the chief medical officer, right, of health business and United Healthcare's vice president of medical affairs. He's also served as leadership roles at Solucent, Humana, HealthSpring, and Alexian Hospital Network. And he's going to talk about the promise of healthcare IT, moving beyond electronic medical records, which is certainly a topic of interest to all of us here. So
Good.
with that.
Thanks. Thank you, Aaron. And good morning, good afternoon. It's nice to be in Portland. And I'm glad I got to see a little fog and sun. That tells me it's definitely the Pacific Northwest. I live in Chicago. I'm going to spend a little bit of time talking about the healthcare technology world after electronic medical records. Most people spend a lot of their time, probably the last 2 decades, when you said that healthcare information technology is a critical part of improving healthcare and making healthcare better. Healthcare information technology was equated to electronic medical records. And so all of the energy was consumed around that. And one of the things that I think is becoming abundantly clear is that there is much more to information technology than the electronic medical record and some of its derivatives. And so this is a little bit about the post-electronic medical record world. Maybe that's not post in the sense of it's not over, but everything else. And where I come from on this is really that technology is means to an end, but you have to put it into context. And one of the first things that often happens is this conversation about, well, healthcare is a very personal thing, and technology tends to depersonalize, and we have to really be careful about it. And I stole a quote from Antoine de Saint-Exupéry. He's a French pilot, actually, and he's written a lot of interesting books, children's books. But he was one of the first. He wrote this interesting quote about whether or not technology actually depersonalizes things or makes things even more personal. And I want you to remember that thought, because I'm going to draw a real distinction between the concept of personalization and in-person, which is something that in health we often talk about, and the role that technology can play. So the context I want to lay before I talk about technology specifically are four themes. These are overlying themes that then help me make sense of several specific technologies. The first one is the concept of value in healthcare. And one of the real challenges we have is this conversation about how much money we spend. And I'll actually say that I don't think that the conversation is really, do we spend too much money, but really, are we getting our money's worth? Because one could argue that if we could eliminate all of the things that we spend more than we should and all the things we spend less than we should, how much we spend might be about what we spend now. It might be more, it might be less, we don't know. But we'd feel a lot better about it because we've eliminated all the overs and unders. And so I really focus on this question of value. And one of the places that we start to go to discover what people, what really people want is when we start asking people what they want from healthcare. And so this is an interesting study. It's a couple of years old, but it was done on behalf, actually, of the pharmaceutical industry trying to understand what they want. And I make this point because the way this question was asked, they asked patients in their own words how they would define value. And if you looked at how patients answered the question, about 40% of patients said, I don't know, but I know one thing. It's not cost and it's not outcomes. And then about a third said, I have no idea. A little bit less than 30% said cost. 4% said outcomes. And 2% said cost and outcomes, which is interesting because from a public policy perspective, what we're trying to do is communicate to our publics that they're getting their money's worth by sharing them information about cost and outcomes, which is fine, except if you ask people what they want, almost 2/3 say, either I don't know or I know it's not that stuff. Now, that's an oversimplified concept, and I want to take it a little bit deeper. But if you ask doctors, doctors put cost at the top, but then almost 30% said neither cost nor outcomes as well, sort of like the patients, right? So what does that mean, and how do you make sense out of that? Well, here's how I make sense out of it. I look back at 50 years of sociologic research on what people want from health, and it typically falls into two buckets. They want care and they want compassion. And care is often equated with the biological part of health care, and then compassion tends to be everything else. And what we've often had is this discourse about things like customer service, et cetera, all those sorts of things. But what I think it really tells us is not that people don't want biological care, but when you ask them questions like this, where they're making relative comparisons, they focus on the things that they can actually judge. And the data will tell us that people actually expect their care to be technically correct. And what they really are judging on is all the other things. And an example I'll give you outside of healthcare is the airline industry. I use this example a lot because I think it's a really good example. If you got on a plane today and you flew to Asia, that plane would have $1,000 seats on it, $5,000 seats, and $10,000 seats. Coach, business, first. Nobody on that plane has a different expectation of arriving safely, right, or on time. You don't crash and coach at a different rate than first class. But you pay $10,000 more for a totally different experience. And if somebody tried to launch a carrier that would give you a first-class experience, lie flat seats, everything else like that, with a coach seat price, $1,000, and got you there almost as safely as the other guy, there's no market for that. Once the market has an expectation of a minimum level of technical quality, it becomes very hard for people to differentiate. So when you ask people questions like this, oftentimes what thprettelling you is, I was assuming that I was going to get the best possible outcome. So it's hard for me to say that, that's pretty much what I expect from you for any level of payment. And all of the competition, all of the differentiation actually goes on for all the other things. And that raises a series of interesting questions that we're going to talk about, because there's a very powerful role for technology around all of the other parts of what makes healthcare a good experience that we'll talk about, and you'll get a sense of where I'm coming from. So this idea that value is more than cost and value is more than outcomes, and value might have to do with things like experience and trust and transparency, empowerment is really important. The next concept is what's going on economically for the delivery system, and this is a very important role for technology, which is pretty much the overarching economic model that we're facing for providers is that payment per unit of service is going down, or at least not going up. And that's really important because that kind of cost pressure has huge implications. If you actually look at why healthcare costs are going up, there's a couple of facts you should know. One of them is the rate of increase. The rate of increase year over year, and you may or may not know this, but the rate of increase is actually at an all-time low. The last 3 years, healthcare has been increasing at the slowest recorded rate for the last 50 years. Now, it's still going up. And if you actually look at why it's going up, there are two components to why it goes up. One is we use more stuff, and the second is we pay more per unit of stuff that we use. Prices are going up. Well, if you look at the relative contribution of price of service and quantity of service over the last decade, you see an interesting phenomenon. That stacked bar graph represents year-over-year increase. Between 2004 and 2008, the light blue represents prices, and then everything else, the red and the green, represent non-price, demographic and utilization. So it's about 60-40. If you look out at 2010, 2011, and 2009, what you see is that the increase on a year-over-year basis was somewhere around 80 to 90% price and only 10 to 20% quantity. So we've had this really interesting phenomenon where the last decade, the primary driver of cost increases has actually been prices of services, not quantity of services. And what's happening is that the marketplace, this is the regulatory marketplace in the private sector, has basically discovered that, has come to the conclusion that one thing they have to do to control costs is they have to control prices. People are going to get paid less for what they do. And if you really want to take this down a level, you start to see things like this. If you look at why it is that U.S. healthcare cost is more expensive than the rest of the world, and you know that we spend twice as much on average per person, you start to look at findings like this. This is just hospital as a component of total cost. And in this study period, where we spent 15% of our GDP and the average of all industrialized nations was 9%, our rate of growth was about the middle, 4.4, where right around the average of everyone else. But our per capita spending on hospitals was about 70% more. But it turns out that it's not because we used more hospital days. In fact, we were one of the lowest consumers of hospital days of all developed countries, yet we spend more than almost twice as much. It's because stuff costs more. If you look at utilization of services, you'll see a mixed bag. But if you look, here's a routine office visit. Routine office visit in the U.S., $89 versus somewhere between $20 and $60. Cost per hospital stay, $15,000 versus $3,000 or $4,000. Couple of interesting facts. A physician in the United States makes between 5 and 10 times an average American. A physician in the 10 other European countries used in a comparator group is between 2 and 3 times a citizen in their own country. So we have this huge disparity in price, the cost of inputs, the physician incomes, the price of these days, these sorts of things. All of this is putting tremendous pressure on the cost of production. If you look at other parts of our economy, when you see this kind of pressure, that's usually when technology starts to get used to extract large amounts of cost out of the system, typically in the form of substituting for labor, creating models where you start to shift work to your customer. These are all areas where technology is going to play. So when the delivery system is faced with this reality that they're going to be required to deliver more services to more people and require more expensive inputs, but not getting any more money for it, then technology has to be brought in order to try to solve for that problem. And that's not just that's not a clinical outcomes conversation. That's a real structural input kind of a conversation. The next big trend that's interesting in this area is this concept of demographics. And it's really important to understand this because the generational issues that are going on now have a big impact on information technology. And you probably know this, but one of the really interesting facts is that if you look at the attitudes towards technology and healthcare, you find that the baby boomers think about the world a lot more like their parents than their children. And so we've got basically 4 generations of caregivers, 4 generations of patients. We have 3 generations of caregivers. You've got the sort of the traditionalists are the post-World War II. Then you have the baby boomers. Then you have the Gen X and the millennials. We have now millennials entering into the workforce. And they think about things in these generations very differently. Now, most of leadership comes out of the baby boom generation. But there are some very marked differences. And I'll give you a simple example in the world of technology that people in this room will understand. But I do a lot of speaking to boards and operating leaders, and this example comes up all the time. Email. So email is an interesting technology because if you survey the use of email under the age of 20, what you discover is it's almost never used. It's actually used by people under 20 for 2 primary reasons: to talk to their parents and to engage in formal communication. And yet email dominates the working landscape. So right now, about 20% of all physician practices use email to communicate with their patients. And there are all kinds of conversations going on around how do we make email more useful and available for doctors to talk with their patients. Now, this is a real example, but think about what's happening. In a few years, physician practices are going to be recruiting young physicians into their practice. And they're going to say, I got great news. You can email your patients to physicians who've never actually used email as a primary form of communication. Now, that distinction is an interesting one because those of you who understand what I'm talking about would say, well, you under 20 use social software. And social software has email attributes built into it. So, maybe that's not really the right distinction. The big difference for people in this room who don't typically use social software to engage in communication between that and email is social software allows you the opportunity to have people you know relate to other people you know without you making the choice about how you want to intermediate it, right? So in an email, I'm an email person. I'm not a social software person. My buddies that I went to college with that we graduated 30 years ago, they send me a funny joke or a picture. I have to decide who I'm going to send it to. But my kids, somebody posts something and everybody else who's a friend gets to see it without that person having to make a decision about how they want to move that information. Now, you think about a medical practice and you think about the difference between a pure email versus some kind of a social platform for a conversation. Suddenly, patients might be able to share information, experiences with other patients, which is right now going on anyway. But now the physician's practice actually becomes a source of that kind of intermediation. So this is a very, very important area. Now, what we've learned is that it's very, very hard for people who don't use these technologies to incorporate them into their operating model. So some of you guys are familiar with this terminology of digital immigrant and digital native. I'm a digital immigrant. Basically, the baby boomers are all digital immigrants. We grew up in a pre-digital world, and we've learned about this later on. I worked for Cisco, which is a company that says it was there at the beginning of the internet, networking company. Our leadership at the time were largely baby boomers. And our CEO said, we do not have enough digital natives on our own leadership team to understand what our markets want from us. The argument they're making is that business leaders actually have to go out of their way to bring people not from their demographic into positions of leadership for the purposes of understanding this technology. And in health, here's an example. You'll see a lot of this. We want to communicate with our 70 or 80-year-old patient. Well, you say, well, they don't use technology to communicate. That's great, but who's their caregiver? It might be a 25-year-old granddaughter. So it's not the patient. It's the patient support system that you need to understand their technology preferences. Similarly, when you ask these people what's important to them, they answer the questions differently. So if you're over 46 and the question is what's the most important factor in selecting a hospital, you'll put physician direction at the top, followed by reputation, followed by prior experience. But if you're under 46, reputation actually floats to the top, not surprising, whereas physician direction is down at number 3. So the relative role of what your friends think, which is enabled by technology, is fairly critical. The last contextual point I want to make before we start talking about technologies is this concept of financial incentives. So we're very much focused on this idea that in health we have this third-party indirect payment model, and if we just created the right financial incentives, good things would happen. Interestingly enough, while health is trying to figure out how to engineer financial incentives, the rest of economics has discovered behavioral sciences and behavioral economics and realized that money alone isn't enough to create choices that people want to make. And there's some studies that are starting to appear right now in the literature around healthcare which really illustrate how far we have to go. And it also shows you where you can begin to see where technology might play a role. So one of the concepts is if we just got people to pay enough money in terms of a co-payment or co-insurance, they would make choices that we want. And an example is choosing cost-effective doctors. So this is an interesting study that comes out of Massachusetts. It's a survey and a simulation. And what they did was they wanted to figure out what would happen, how do people make choices about going to a high-cost or a low-cost network. So in this example, there was the preferred network of doctors where the patient had a $15 copay if they went. Then there was the non-preferred network where the patient had a $50 copay if they went. And the first example was, well, if you know nothing except a $15 network and a $50 network, how would you sort? Turns out 89% of the people would go to the $15 network, so the low out-of-pocket, and the rest would go to the high out-of-pocket. Now, if a friend or family member told them that they should go to the more expensive network, 89 goes down to 45. And if a doctor told them they should go to the more expensive network, 89 goes down to 24. So huge drop-offs. Then the next question they ask is, how much money would one have to spend to overcome the recommendation of a friend or family member or a doctor? And it turns out that you'd have to spend $290 to overcome the recommendation of a friend or family. There's only a $35 spread on the copay. And you'd have to spend about $440 out of your pocket to overcome the recommendation of a doctor. These are in excess of what the total visit costs. So to simply tell people to create financial incentives and to ignore the fact that these kind of factors are driving decisions means we're really missing what the rest of our experience in life about decision making and the role of money is. In fact, there was an interesting study done on drugs and drug discharge from a hospital, and there's a lot of effort to try to get people to take their drugs when they go home. And what they discovered was even if you take a drug, you go into the hospital for a heart attack, you're discharged with medications, and you make the drugs free, less than half of the people will take the drugs for the condition they were just hospitalized from, even when the drug is free. So it's a really interesting statement, because that's exactly why they came to the hospital for. So it's not so simple as money. Now, take that context and start thinking about, well, what is historically the role of technology been? And the way I think about it is we've really focused on, to me, healthcare, at this point, we really understand that it's a series of interactions between people and other entities, people and other people, people and resources, people and information, and all of the electronic health record and all of the emphasis on healthcare IT has been focused on the relationship between people and information. And we haven't really thought as much about the role of technology in these other areas. And what we're starting to see now is all of the influx of interest in the role of technology in enabling all of these other pieces. In fact, there's a whole bunch of interesting conversations going on, including the relative role of, can technology substitute for people, or is technology just simply there to enable people in order to do their natural thing? Can you actually replace a human or a doctor, or is it always about augmenting them? And this is a very interesting debate going on across lots of sectors in terms of the relative role of technology. And we can talk a little bit about that later on if you want to. But I want to focus on 3 technology trends outside of the electronic medical record that I think are going to have an impact on these healthcare problems I just described. And we'll take them to whatever extent you want to take them. And I'll go through them, and then we can go back and have a conversation about it. So I want to talk about the 3 trends. Then I want to talk specifically about 2 trends and their healthcare expression. One of them is this concept of virtual health. Used to be called telehealth, called care at a distance. And the second one is social technology and social networks and its relative role, and where some of the possibilities exist. So the 3 big trends are big, personal, social. That's kind of how I think about it. Where's technology going? And I basically say that technology in general is becoming big, personal, and social, and then I want to track them a little bit into what they might mean in terms of health. So big to me is interesting because we're all used to the abundance of data that's going to get created. I just put a statistic up here for the illustration. 2015 will produce that year will produce data equal to 120,000 times the total of all written words for all recorded history. There will be 3 IP addresses per person on the face of the earth by that year, which is, think about that. That's a profound number, 3 IP-enabled devices or addresses per person. But what's really interesting about this is that when we think about big, there's been this whole emphasis on big data being about large amounts of data. But what other industries have realized is that the power isn't necessarily simply in quantity. It's actually in making sense of disparate information. And where industries have actually started to, like retail and financial services, have started to really do interesting work is by taking data, for example, data from your buying behavior, and intersecting it with other data, like data from social sentiment or data from other sources. And in health, we keep thinking about big as more of the same and haven't really necessarily mentally crossed the Rubicon that big data might not be about taking a little bit of EMR data to a lot of EMR data, but actually contrast that with taking EMR data and combining it with something else, some completely different form of information. That could range from self-reported data, external financial data, social sentiment data, all these sorts of things. The 2 that I want to spend more time on are personal and social. So let's talk about personal for a second. personal is an interesting concept because personal is actually something more than just mobile, even though I use a mobile statistic here to illustrate a point, which is that if you followed the trends for television, watching television on your cell phone, you remember about 8 or 9 years ago, there was a big movement to something called mobile TV. And the idea was that you could watch TV on your cell phone. And that actually disappeared, and it got replaced with what the cable companies now refer to as TV Anywhere. Because what they realized was that people didn't want to watch TV on their cell phone. What people wanted to do is they wanted to watch their TV content wherever they were at on their own terms. If the only device they happened to have was their cell phone, that's great. But the minute they walked into a room and they had a bigger screen or they had a pad, they wanted it on that screen. And what happened with healthcare was that we started to get focused on the cellular phone as a device and lost sight of the fact that the issue wasn't on that form factor. The issue was that people want to consume information on their own terms wherever they're at. And so what's happening is there's a series of technologies flowing in, and the primary objective or the primary need is that people want to consume information that's specific and unique to them on their own terms. Part of it might be physically where they're at, so mobile's an example, but there are other issues here, like the concept of context awareness. Do people here understand what the concept of context awareness is in technology? Have you heard of this term? A few people. So context awareness is basically technology that's adapted to knowing who you are and personalized to your circumstances. So if any of you have used a couponing technology called Shopkicks or an equivalent of it? Shopkicks is something my teenage kids taught me about. It delivers to your cell phone the coupon of the day for the store you happen to be standing in at that time. Now, how does it know that? Well, it knows a bunch of things. First of all, you sign up for it, so it knows something about your preferences. But how does it know when you're in a mall that you're in Victoria's Secrets and you're not in Abercrombie? Because it can't tell from Wi-Fi location. That's too close. They actually figured out that you can emit out of the PA system of a store an inaudible frequency sound that your smartphone's speaker can detect that is registered to the store you're in and localize you to being in that registered retailer. So it says, okay, I know you like Victoria's Secrets because that you used to buy there. I know you're standing in Victoria's Secrets in this mall at this given time. I'm going to deliver to you the specific coupon of the day for that store right there when you're ready to check out. If you buy an authentic Gucci bag or any other product right now, there is a small chip inside of it. And if you walk into a Gucci retailer, it knows what you bought and when you bought it and will change the visual displays to reflect what's interesting to you based on your buying patterns. So this notion of context awareness is very powerful because in health, we think about information. Basically, we tell people, go search the table of contents and find what you want, right? As opposed to, I know who you are, I know where you've been, I know what you're interested in. I'm just going to shoot to you the information that's important to you at that point in time to make a decision. So personalization is a very interesting concept. Another concept behind personalization is this concept of augmentation. Augmentation is this idea of taking what is essentially currently a physical experience and superimposing information on it to make it more interesting to you and to change its appeal. So sports on television. Sports on television started in the 50s as grainy black and white. And it was kind of an interesting alternative, but no one would ever think about watching a game on television if you could go to the game. And then technology moved along, and we started to add better quality imaging. Then we started to add instant replay. Then we started to add scores. And by the 90s, there was a whole discussion about whether it was better to go to a game or watch the game on television, right? You probably remember that. We had suddenly demonstrated there is the first order of distinction between an in-person experience and a personal experience. And the stadiums had to respond by bringing the screens and the information into the stadium. If you couldn't get the information that you could see on TV, you wouldn't go to the game. Now, here's the point I'm making. Here's the point I make with respect to healthcare. We have this concept that the highest order of a personal healthcare experience is one that is delivered by a person in person. That's the gold standard for service. I would argue that if we just follow our experiences in other parts of our lives, there is a big difference between a personal experience and an in-person experience. And what people really want is a personal experience, not to be confused with an in-person experience. And it's a high reliance on technology. So the concept of augmenting your physical experience with information might actually create something more personal. And I'm going to give you a real living example of that on what's going on in telehealth right now as a way to show you that telehealth is an interesting intersection where we might actually create a more personal experience, even though we separate the doctor and the patient physically, and they're not physically in person. Another area that's interesting in the world of personal information is the fact that we've moved to this highly visual environment, visual information where people can see things. There's a lot of interesting data that says that when people see something, as opposed to read it, they retain it, they think about things differently. Discharge instructions, for example, with a video given by a person are very different than discharge instructions that have to be read or that someone has to read. And so people are beginning to understand that visual information is a very powerful form of communication that can be customized to the way you receive information. And that's becoming a very big part of how people are communicating. The last big trend is this concept of social. And here's a really interesting and important thing. When we think about social, we think about things like Facebook. Facebook is fine. Facebook is a great form of social interaction. But what's really going on here is it starts with the assumption that all humans are naturally social. They've always been. And technology is a way to allow people to extend their natural social tendencies beyond the ability to have, beyond their physical encounter. So what did Facebook really do? Facebook began to solve for the kind of things that people did in their own community square, but you weren't constrained to the people that you happened to be living in the neighborhood with. Everybody that you had some commonality with, some common interest with, you could begin to have an interaction with. The technology really just allowed our natural human social instincts to be delivered on a very large scale. And it started with simple things like the sense of community. But now you're beginning to see people use social platforms to do things like allow users to create their own content, which is a very interesting and important area, and we'll talk a little bit about that. Self-service. This is a really critical area. Technologies that are used for people to serve themselves started out in, for example, this got a real big lift after the natural disaster, starting with the tsunami in Phuket and then the hurricanes in Haiti, that basically rescuers were putting up various kinds of websites where victims were able to match themselves with people who were looking for them completely outside of the role of the government. Basically, survivors and people who are out there trying to deal with the recovery on their own. And it's become a very important part of how governments are actually starting to think about how they can serve their communities. The basic argument is this: people need more services than we can provide. Rather than us providing services, we provide technology, and then people go take care of themselves. And I'll give you an example of that in a second. And the last, and the interesting point here on games is people have recognized that humans like to play games. And so you can take advantage of that with a social platform, and you can begin to engage in these kind of gaming behaviors. And here's an interesting example I put over here. Well, you can see the list people have talked about. What does gaming do? There's a whole hypothesis around kids who play games make, for example, faster decision-making and speedier thinking. There are actually surgical residencies now that are starting to either look for surgeons that are gamers or train them to be gamers because they think they actually manipulate the technology, the laparoscopic technology better. They can multitask better. They have better visual processing. It's actually fascinating. There was an interesting study published around children that said that if you have a choice between a child playing a game and watching television, you want them to be gamers because that's an active skill that actually teaches them a series of tasks versus watching television, which is a totally passive skill. This thing called stick was actually built to help people meet their health goals, and actually a whole bunch of other goals. And it's a really fascinating concept. It basically takes advantage of the fact that people like to compete with themselves, but they need a platform for it. What the guys at Stick learned, I was talking to the founder about this, was people need an incentive, and so let's pick something like weight loss. So the traditional way of I'm going to lose weight typically doesn't work. Then the next question is, well, who do you have to compete with in order to lose weight? And they said, well, I'm going to set up this model where I can nominate, I can create a reward system where if I lose a certain amount of weight, I get a reward back, and it might be a financial reward, it might be some other points. And they said, well, that kind of works, but it doesn't really work. You need a referee. So then they allowed you to introduce the concept of a referee. It said, so I have to ask Aaron, and Aaron has to validate that I lost weight. And if Aaron validates that I lost weight, then I get my reward. And what they found was what people really wanted to compete with, what really made a difference, was they developed this concept called the anti-charity. And the anti-charity is the following. People were most motivated to stick to their goals if failing their goals resulted in reward for something they hate a lot. So people actually said, like, if I pick a charity, pick a cause I hate. If I register my credit card, and if I don't lose weight, and Aaron doesn't say that I met my weight goal, then money leaves my bank account and goes to the charity I hate the most. And they found that people actually lost weight when they used this technology to game themselves into doing those sorts of things, which I think is fascinating that people would actually volunteer to do that. It's really fascinating. So let's talk about telehealth for a second as a specific example of these technologies. And this is a really interesting one because I think it's worth understanding where this is going. There's a lot of interest by investors and entrepreneurs. Venture capital, if you read venture capital's current investment thesis, telehealth is one of their top areas for investment, technology investment. And why is that? It's not because we're trying to solve the problem of the people in rural Alaska or the Indian reservation. The concept of using technology to solve for people who are unserved or underserved is interesting, but it's a relatively narrow opportunity. What's really going on is a recognition that technologies like virtual care actually create an alternative for the already served and potentially create a superior care model for the already served. Now, how is it that you can take a normal doctor-patient relationship that works today and suggest that I can introduce telehealth into that environment and actually create a better experience than the already served experience? Well, in order to do that, you have to meet certain thresholds. The first thing you have to do is the technology has to be at least good enough. And what happened was people started taking high-definition, immersive technologies from business conferencing and starting to apply it in telehealth. And what they realized is if the technology is good enough in terms of its audio-visual capabilities, you can begin to register levels of satisfaction with a virtual encounter that are in the 90% satisfaction and willingness to recommend. Now, normally, a live physician encounter will register in the 90s, but a traditional telehealth technology is registered in the 60s. So getting the technology good enough for people to say willing to recommend in the 90s just gets you to parity. But getting to parity wasn't going to be good enough. What you actually had to say was, what can the technology do that can never be accomplished in a traditional face-to-face visit no matter how hard we try? And what people started to do is realize, well, there's a couple of things that you can do that are not possible. You can have one-to-many. You can have one patient and many doctors. So, for example, and people are starting to build these kind of business models, you go in to see a doctor, and the doctor consults with another doctor while you're in the room, as opposed to you having to go out and seek the second doctor in the normal sequential model. And another example is if you have cancer today, if you're lucky enough to go to a cancer center that uses this method, then some of those patients may get a collaborative conference to plan out their treatment. And that is in many ways considered the gold standard for cancer treatment. But in most cases, you don't get that opportunity, right? Because it's too hard to convene the doctors, much less the doctor and the patient. So you pretty much get the recommendation of the person that you're in front of. Well, technology lowers the cost of convening and makes it perfectly possible for people to get the advantage of a group collaboration and a group decision-making in a way that wasn't possible. And you're starting to see in the U.S. and outside of the U.S. these ideas of, well, why don't we give every single patient a collaborative visit where all the experts are lined up and we go over their case. At least, we can do that with technology. Technology lowers the cost of convening. So you see those kinds of things. But the thing that's really interesting is this issue of augmentation. So some work that has been done on telehealth stumbled into this actually somewhat by accident. What they did was they did examples where a patient would come in and see the doctor, and the doctor was using remote diagnostic equipment, so an electronic otoscope to look in the patient's ear. And what they decided was, well, let's let the patient see the same eardrum the doctor's looking at. Normally when you go to see a doctor, he puts a scope in. You don't know what the doctor is seeing. Well, in this electronic otoscope world, the doctor was looking at the patient's eardrum. They just showed an image of the patient's eardrum back to the patient so he could see their own, or she could see their own eardrum. Or heart sounds. The patient you can hear the heart sounds on the same electronic stethoscope as the doctor can hear. In Scotland, when they first did this, they actually were taking patients into an emergency room, and they were doing different trials, including giving the patient both a virtual and an in-person visit, and they were asking the patients how they liked them. And they were getting a very consistent subset of patients that were reporting that they actually liked the virtual visit better than the face-to-face visit when given both options, when experiencing both options. And the reason they said they liked the virtual better was actually two of them. One of them is they thought the doctor paid more attention to them. Now, this is probably an artifact of what happens when you have a screen as the method for an encounter. There's this natural sense of focus. And whereas in an exam room, there's a lot of ambient distractions, and when the doctor's standing up and has the hand on the door, there's a tremendous amount of distraction, because they actually timed it and found that the doctors were paying the same amount of time attention, but the patients were registering a different perception of attention. The second is the patient said that they loved seeing their eardrum and seeing their heart sounds. They'd never seen that before, and that made the visit much better. So here's an example of where augmenting the visit with information like the biologic view of your own body was far more important than having a doctor in the room with you. And if you start thinking about how this might play itself out in a disruptive fashion, you could have a delivery system that does things the old-fashioned way, and then you could have a delivery system that decides that they want to go into a geography, but rather than necessarily building all of the physical capacity and putting the doctors there, they're going to make the investment in telehealth technology where they have some of this remote equipment. And they compete with the physical world by offering up this world where you get this new enhanced visit. And the promise is, well, you can see your own eardrum, and you can hear your own heart sounds, all those sorts of things. You might begin to see a real interesting competitive differentiation. Now, what would happen is that the local market might respond by saying, you know what, I'll just buy that technology and use it myself. Now, what's better? Now it's me in the room plus the technology. And that might work, but they might also discover they don't need to be in the same room as the patient. That's not really what the issue was. The issue was the personalization. This is one of those areas where you start to think about the distinction between the two. For those of you who might be familiar with the robotic surgery, the Da Vinci robot, the value proposition around the Da Vinci robot was originally this idea of doctor specialty physician in one location, patient in another location. And then the second order benefit was supposed to be that the technology basically compensated for motor issues, like it fixed up, down, right, left, and it fixed hand tremor, and so you got a better clinical result. But I've actually spent some time talking to the guys who were some of the original investigators, and they said that the actual revolution of the robot hasn't been recognized yet. The real revolution is going to come when people recognize that when you take a physical interaction of surgery and you put a digital pathway, you can now introduce information in and augment the surgeon's hands with tumor markers, with imaging information. And that's a different surgery than the surgery that's performed by physical direct contact. So the idea of going from a physical platform to a digital platform allows one to augment the physical experience with information. And that's where we start to begin thinking about, well, how do these technologies work? They actually start to work by creating a totally different experience. So let's go back to that first slide that I showed you where the study of value, right? What do people want? Well, we don't know because we haven't pressed the envelope. But the ability to augment and the ability to show a different value might actually come when you start to use technologies to create this platform for these kind of augmented experiences. The last example is the concept of social platforms. So I started touching on them, but I'm going to give you a few specific examples. One of them is this concept of using a social platform for patients to create their own content, do their own learning. this is a really interesting and important study in that it illustrates the power of it. So patients like me, some of you might be familiar with it. It's a website that's been around for probably 8-9 years. It was created by an entrepreneur based on his own family conditions to allow patients with serious clinical illnesses to find other patients with similarly serious clinical conditions on the theory that nobody knows what I'm going through better than me or people like me. My doctor, my nurse can't explain what it's like to have my condition. They can't explain to me what the side effects really feel like. And that business model worked out fine. Then they found a very interesting accidental finding that really shows the power of the social platform. And it was published a few years ago as the first ever patient self-organized clinical trial ever published in a peer-reviewed journal. And it basically worked like this. The patients who had this particular disease, neurologic disease, ALS, had been using lithium, which is a drug for bipolar depression, off-label for a while because there was this concept that somehow it improved your cognitive capacity. The problem with lithium is it's very dangerous. So there's a very narrow therapeutic window between toxic and effective. And what happened was that there was the chatter on patients like me about does it work or doesn't work? Does it not work? And they decided they were going to organize their own trial, literally. So some patient nominated up an Excel spreadsheet. They created a symptom list. And people reported, did I take lithium? And did it work? Did it not work? And patients in real time watched what other patients were saying. And the investigators then looked at the patients like me data for off-label lithium, and they tracked it. And they found that when the site first made this information available, the use of off-label lithium got really high. And then patients started discovering the drug didn't work like they expected to off-label. And the patients like me community basically self-extinguished lithium as an off-label drug in their own community with zero intervention by any doctor or drug company. That is complete self-organized practice. And what that tells us is that in health, as we're trying to figure out new and innovative models, including models that might be lower cost, this concept of making platforms available for people to start solving their own problems begins to get surfaced in a way that we haven't thought about at all, and as opposed to everything being curated by the medical community. And I touched on this concept of municipal governments. Many city governments now have things like traffic and pothole finding software. And some of you may be familiar with this, right? Where you report that you found a pothole. It saves the government money because they don't have to drive around and document it. It also means they can fix them faster. And fixing them faster isn't just a nice thing for votes. Actually, in many municipalities, the city has liability for the damage to a vehicle of an unrepaired pothole. So it's actually a risk management thing. The faster they get the pothole fixed, the less they pay in insurance claims. So it's a concept that says let the technology have the people do their own work. Well, in health, we haven't really thought about that yet. But this idea of moving work to your customer, which is happening right now in airlines and hoteling and banking, there's a huge opportunity for health to do that. And think about what that means. There's actually two benefits to that. One of them is some of the cost, when you shift some of the cost back to your customer, it lowers your cost of production. And remember, we have a challenge right now, which is we have to figure out how to lower our cost of production. So you do what other industries do. You give some of the work to your customer. But there's actually a second benefit. What people have learned is that that consumers, customers, people actually feel more ownership and more engagement when they do some of the work themselves. It's not just about shifting the work. It's actually about creating a different level of engagement. If the sort of best described example of this is the Betty Crocker cake mix. And some of you may know the story because it's been written about before. Do people know the story? So you have to put an egg in when you do the Betty Crocker box mix, right? But not because you have to do that. They can make the box fine with all the content. They discovered that when they took that content out, if you added the egg, you felt like you baked a cake. It's completely about this perception of participation and ownership in the cake. So people are starting to say, well, wait a second. Why don't we start thinking about technology to shift some of the work back to our customers, partly to get the work off of us, and partly to make them feel like they're a part of the process and make them feel more engaged. And you can see in health how that could very naturally be a useful tool. So the concept of using social technology and social platforms to get at all of these layers is hanging out there. And I think you're going to begin to see people working on that. The last concept around social technology is that there's actually evidence that at least some clinical conditions have a literal social component to them. And there's a concept called social contagion that's been documented for a few diseases. And I just put this up here to illustrate how far this social thing goes. So Nicholas Christakis is a physician and sociologist at Harvard. He's a well-regarded expert on social networks and clinical disease. 2007, he published the article in New England Journal of Medicine about obesity. And basically, the study was something like this. The probability of a person being obese is directly related, or most strongly related to whether their friend or their friend's friend is obese, regardless of the geographic proximity of the two people. And the fact that people next to you or in your community are obese confers almost no risk. So he actually lists these risk factors from this study. So it's almost a 200% chance if you have a mutual friend who's obese, your risk of being obese goes up by 200%. Your risk of being obese if your spouse is obese is actually less than 1/4 the risk of a mutual friend. That's got all kinds of stuff behind it that are probably for a different conversation. And an immediate neighbor has essentially no risk. So he makes this point because he says if we're trying to figure out how to solve for obesity, it's one thing to focus on food in the cafeteria, but it's another thing to understand what the friend patterns are. And in fact, if we could map them, we could consider how we might want to somehow participate, intervene, engage the social relationships. The technology and the information allows us to create a map of social relationships and think about how we may want to engage. So it's not just, all these layers live underneath this idea of if we can understand humans' social behaviors and somehow measure and intervene, there's lots to be done. So let me end with this quote from 1834. That device over there is the precursor. It's actually the Lennox stethoscope, and it's roughly in the same form it is today, except that instead of a single piece that goes into one ear, there's two soft, flexible rubber pieces that go into both ears. And this is what they wrote about the Lennox stethoscope in 1834. That will ever come into general use, notwithstanding its value, is extremely doubtful because its beneficial application requires much time and gives a good bit of trouble, both to the patient and the practitioner, because its hue and character are foreign and opposed to all of our habits and associations. So some of the stuff that I said to you might pretty much fit right into that, right? And you look at it, that stuff is never going to work. It might make sense. But remember, you go back 170 years, and that's pretty much what they said about the stethoscope, which we're still using today. So thank you. I've got a few minutes. I'll be happy to take any questions if you have any. And thank you for having me here. I appreciate it. That's my contact information, my email if anybody wants to. Email, see notice.
Yeah, generation.
Did you get that right?
So just remember to push the button when you ask questions so it can be recorded.
Anybody have any questions or no? Question, go ahead.
I have a question. I don't know what button to push.
That's okay.
The big red shiny button.
Yeah, just talk.
So my question is, the telemedicine concepts that you laid out, the collaborative case conferences or collaborative patient visits, conceptually or academically makes a ton of sense. From a workflow standpoint, completely flies in the face of how traditional practices are structured.
Yes.
So is anyone doing it right?
So really important question. And why it hasn't, part of the reason it hasn't taken off is people are trying to incrementally layer in the existing workflow. What you're beginning, the businesses that have become successful are the ones that have basically tried to build, for all intents and purposes, built-for-purpose telemedicine workflows. Because if you try to do it, it's very hard to commingle it in the existing example. So, so I'll give you an example right now. The two telemedicine companies that have acquired the most venture capital money in the last 3 years both focus on, think of them as they compete largely with urgent care and physicians. They're American Well and Teladoc, and their basic concepts are people who are traveling or at home and can either, MD Live is the third one actually, they can, it basically brokers doctors who have free time with patients who want to be able to have a conversation with that doctor and creates an economic model that makes it work for everybody. because the only way for this to work is for doctors who have dedicated themselves to a delivery system that works this way. And the technology allows a little bit of load balancing, so the doctors can say, I'm going to be available between 3 and 8, and so put me on call for those 3 hours. But what we found is if you don't build a delivery system that actually contemplates this, it's almost impossible to do anything other than add cost. Kevin?
Patient telemedicine anymore. Now we've got virtual nurses showing up that people are actually starting to try where you won't even have a person go into the room.
And that actually raises a really interesting conceptual question. And it's on many orders of magnitude. One of them is that for telemedicine to really be effective, it has to change the economics of labor. If you actually look at the long-term total cost of the telemedicine technology, if you take a doctor and a patient, and all you do is separate them by space, but everything else is the same, it doesn't actually affect the cost very much. So you have to begin to think about what you can do, either by using one-to-many, so you're scaling resources, or you're beginning to use technology to do some of the work on its own to have an impact. So a lot of those things, I think, are the beauty of the telehealth is it's a mechanism for beginning to add these other kinds of things that will effectively have labor cost reduction. However, the counterpoint to that is this very significant debate about whether one can actually ever replace clinical judgment in any meaningful way. And so how far these technologies can go, I think what is going to happen is the marketplace is basically allowing us to take what is now a very monolithic model. So no matter how simple or complicated your problem is, your choices are go to a doctor, and create a whole array of options. For those that you need to go to a doctor, you go to a doctor. For those that you can go to a doctor or a group, that's different. And for those that can be served by technology and some kind of self-service, great. I think what really technology does is it allows us to unpack this relatively expensive delivery model and allow lower cost ones to come in, but never to replace those things for which an in-person face-to-face visit is necessary. And if you have a complex condition where it might be life-threatening and someone's going to do something, you probably don't have an alternative other than to physically go in the room and be with that person. And nobody is suggesting that that's ever going to go away. So it's really about an array of choices.
Do you think it would ever be possible for technology to enable context-sensitive teams to assemble on the spot for a given patient? Because
that's probably. I mean, the point would be that if everyone, if you knew something about what the person needed, at least probably by some formula or some algorithm, the challenge would be that you kind of people are already experimenting with that right now. In that there have been experiments done like this. There's not like a commercially available where individuals have identified themselves by their expertise and their location, and so to the extent that you have a problem that needs to be solved a specific way, it knows who's physically the closest. I've seen actually people have built up and tested prototypes where it knows how to assemble a team of people that actually know the right services. But it's not, the technology I think is probably simpler to get to than some kind of a sustainable business model. Were you thinking about something specific?
I was just interested in sort of what the ramifications would be if you're sort of randomly assembling a group of people that specialize in a particular area of the patient, like what the team dynamics would be like when you do that.
Oh, that's an interesting question. It's probably a problem. I mean, because it's not really a team, right? I mean, it has because they've never worked together. I think that's actually a really fair question. Probably a question that would have an issue, would have implications.
There is a exact model of that is in search of a solution, and that's the classic malignant diagnosis patient whose problem will be presented at the next tumor board.
Yeah, right, exactly.
And how to get 4 specialists from different domains available at the right time.
Right.
It's hard enough to get an appointment for most physicians that you're put off by a month. So to get an appointment with 4 simultaneously could be 6 months.
Right. That's why I've said, in some ways, there's not really been a mystery about how certain collaboration creates better quality care, but the cost of convening is so high because physical proximity is the only way to collaborate. And the idea is that as collaboration technologies begin to lower the cost of convening, more people can benefit from collaborative care is the basic concept. Go ahead.
Hi there. My question is regarding the decision support system. So one of the implications of implementing technology is that you can access various information from different sources at the same time. IBM is using Watson. I'm interested in knowing what are the other cheaper decision-making support systems which can be used by maybe on-demand healthcare systems or other facilities which can't afford a Watson.
Well, that's an interesting question because, I mean, if you actually think about it, the first primary objective for a Watson is it's a super fast index and lookup tool, right? That's really, you feed in all the information and it has the ability to retrieve. It creates no knowledge. It's just a search tool. And I think, I guess part of the problem you often have is that the nature of some of the questions can be often answered. I think the technology is moving along pretty quickly. Oftentimes, though, the question is, do you need to look at all the data in order to answer a question or just a subset of data? Because the whole speed and retrieval is somewhat related to that. And if you start out by sort of saying that every question you have to go through everything to find, you get one set of activities. But many times these questions actually end up being answered by a relatively consistent subset of data, which is why people start to try to create smaller domains. I don't know if you guys have any thoughts on that question about the speed of technology. Yeah. Right. Part of the interesting question, of course, is part of the purpose for decision support is to augment the frailties of human decision making, right? So it intentionally has to do things that we typically try to take shortcuts. I mean, our natural tendency is to make pretty good decisions using shortcuts, but we also screw up. So you have to build this technology to sort of not take the shortcuts in order to find some of these things. But right.
All right, well, we're a little over time, so let me thank our speakers
Thank you.
one more